Good afternoon. And this is Dr. Fasika Witingraf from EDPA. I'll be moderating the session today. Today's webinar is the role of dental practitioners in the management of oncology patients. This is the 62nd webinar that has been hosted in the Competence Professional Development Office. So for today, we have our speaker, Dr. Mikhail, who is a clinical oncologist. Just a brief profile about him. He has graduated with his undergraduate degree from Haromaya University, and he did his specialty in clinical oncology from Haromaya University. As a professional experience, he has worked as a clinical oncologist, a lecturer, head of emergency department in various leadership roles. So just to say a bit about further trainings of Dr. Mikhail, he has fellowships on advanced radiology and also radiological planning and training from various countries such as Netherlands, Ghana, and the United States of America. So he has been in different leadership roles in management experience. He also has surplus research and publications. He is well known for his advocacy on the support system of patients with breast cancer and oncology patients as a whole. So he has various certifications granting awards under his name. I would like to welcome Dr. Mikhail to the podium, and we really appreciate your presence here, and we are honored to have you. Please go on.
Okay. Good afternoon, everyone. My name is Dr. Mikhail Shewal. I am an assistant professor of clinical oncology. Today, we have really a beautiful program considering the role of dental practitioners in the management of oncology patients. So I have nothing to disclose. So this is a really a good invitation to teach you about radiation and also chemotherapy and also oncology. So the outline starts with introduction and the Ethiopian cancer epidemiology, and the part one will be about the head and neck radiation oncology patients and common side effects and management. The part two will be the medical oncology patients and common side effects and management. Then I will be presenting the references. So when we start the introduction, in 2023 only, over 54,000 new cases of oropharyngeal cancer, as well as nearly 2 million new cancer cases were projected to be diagnosed in the United States. As dental practitioners, you all are likely to encounter these oncology patients and these cancer patients as pre-diagnosed, newly diagnosed, or post-oncologic treated patients. This lecture will try to address the role of dentists in the management of head and neck radiation oncology patients and hopefully medical oncology patients. So I brought some good data from the Global Cancer Observatory. This was done in 2022, and as you can see from the picture, it clearly delineates that over 80,334 new cases will be diagnosed in Ethiopia. And the map, you can see also the number of days annually will be almost 54,698 patients will die from cancer in Ethiopia. And a lot of people think that we don't have that much of cancer burden in Ethiopia, but unfortunately, we do see a lot of cancer patients in our country. So when you see the incidence of number of cases, for males, it's usually supposed to be around 27,713, and for females, which is almost twice that, which is around 52,621. And from this table, you can see easily that the number of the top 10 cancers in Ethiopia. The number one is breast cancer, which accounts almost around 21%. The second one is uterine cervix, which accounts around 10%. And the third one is colorectal cancer, which accounts around 82%. And the fourth one is leukemia, and the fifth one is non-Hodgkin lymphoma. This is just to show you how difficult our epidemiology has been over the past 2 decades. But these days, we are now trying to establish a cancer registry for the whole Ethiopia, and hopefully we'll get a good number of patients from everywhere. But this is a data which is extrapolated from the Addis Ababa Cancer Registry. And you can see below down, there is a nasopharynx, larynx, and also hypopharyngeal carcinoma or pharyngeal carcinoma, which together can be in the top 5 diseases. So that's why there is a need for a multidisciplinary team discussion among oncologists, also dental surgeons, and also dentists. Then comes the head and neck radiation oncology patients. This is the number one case that I wanted to discuss with you. So the majority of head and neck cancers include squamous cell carcinoma of the oral cavity and the oropharynx. These tumors are unified by a common anatomy, and it can be difficult to manage due to the proximity of vital structures. So this is really a good picture. You can see from the picture that this is a squamous cell carcinoma of the tongue in a 59-year-old patient with a significant history of tobacco smoking. So in Ethiopia, to tell you about a little bit about the epidemiology, we always see patients in late stages, either in stage 3 or stage 4 disease, which has a really a poor prognosis for cure. And because of that, the morbidity and the mortality rate of oncology patients in Ethiopia has been very, very poor. And you can see from the picture, really, the tongue is literally has been disrupted, and also the normal structure of the tongue is neither visible, or the mass has distracted every part of the tongue. Then the next picture comes with a human papilloma virus negative squamous cell carcinoma of the left tonsil. This is a 69-year-old patient with a significant history of tobacco smoking. And you can see from the picture, the left tonsils have been ulcerated, and also infected, overlying infection has been there. So these patients are really very difficult to treat. And this is also almost a locally advanced disease. If we have the CT scan of these patients, you might have at least an ipsilateral lymph node or a contralateral lymph nodes. So head and neck cancer patients regularly undergo radiation therapy, either as a primary or adjuvant therapy in combination with one or more modalities. These are chemotherapy or surgery. So usually when they come to your OPD, for example, seeking help for the head and neck cancer, usually they will have either a chemotherapy or a surgery or a radiation therapy. So treatment field planning is a critical part of radiotherapy management of head and neck cancer. So the plans are drawn using computer tomography image, which we call CT image, to encompass the gross extent of the tumor, areas of potential microscopic involvement, and high-risk lymph nodes. So usually what we do is, if the tumor, the gross tumor volume, we call it gross tumor volume, that is the one the patient come with. So after you see the gross tumor volume, usually since it's a cancer, there will be a microscopic disease around the gross tumor volume, so which we call it clinical tumor volume. This is because of the microscopic disease involvement of the area. And then comes the planning tumor volume. This is called the PTV. Usually the planning tumor volume is accounted for those setup errors. For example, when we treat patients, the patients might move, or might have difficulty to stand still, or to be on the machine. So we will account for that. And the therapeutic radiotherapy standard fractionation of head and neck cancer entails 2 gray per fraction, given 5 fraction per week for 30 to 35 fraction. This is because when we give radiotherapy, usually the radiotherapy machine will have a rest on the weekend, especially on Saturdays and Sundays. So when you see radiotherapy patients, they usually will have radiation treatment from Monday to Friday. They usually will be given this 2 gray every day, and it takes around 5 to 10 minutes for every patient. And if you take, for example, nasopharyngeal carcinoma or pharyngeal carcinoma patients, or hypopharyngeal carcinoma patients, even laryngeal cancer patients, we usually give them around 70 gray. So that can be divided into 2 gray per day. So they will have at least 30 to 35 days of radiotherapy. So imagine when these patients come to you with radiation complications, they usually will be treated with this radiation at least for 30 to 35 days. So this is a good picture, really. I really appreciated this picture. So from the picture, you can see that the red dot easily will tell you about the gross tumor volume. So that is the volume defined by the CT scan imaging and clinically. And you can see also the green circle. The green circle around the red line is designating the microscopic disease. Then comes the blue line. This is called the planning tumor volume. So we call it planning tumor volume because this accounts mainly for the setup error during the radiation treatment. So the patients might have a difficulty to stand still, or they might have some kind of movement. So this should be accounted for the treatment volume. Then the orange lines come. So the orange, as you can see from the picture, this is the 90% coverage for radiotherapy. So once the radiation oncologist prescribe a dose, for example, I can order 70 gray to be given for 35 days. This accounts around 2 gray. So when I give this order or prescription to the medical physicist at the radiation center, they usually will be prescribed for at least you have to cover 90% of my prescription or 95% of my prescription. So that's why the orange line is there. Otherwise, if he can't, the medical physicist can't cover the gross tumor volume or the disease with 90% coverage of the prescription, there will be a risk of recurrence. So I wouldn't accept the plan for these patients. Then comes the next picture. As you can see, this is really a good picture. This is a treatment field plan for oncology patients who received adjuvant radiation therapy for squamous cell carcinoma of the face. So you can see from this image, this is on the right lateral side of the patients, and you can see also the neck, the lymph nodes has been contoured well, and so on. So from even this image, the blue is the one that is defined by the CT scan image. The radiologist will say that there is a disease in the neck lymph nodes, especially in the internal jugular, around the internal jugular vein, and they will tell you there are upper, middle, or lower cervical lymph nodes, and also there is involvement of the mandibular bone or the face, and so on. So as a radiation oncologist, you have to contour every disease starting from the head, like the mandible. You can contour the oral cavity and so on, and then the lymph nodes. Then once the blue line is contoured or the gross disease has been contoured, you have to account for the microscopic disease of the cancer. So because of that, the yellow line is there. It is called the clinical tumor volume, or we call it the CTV. Then after the yellow line, I don't know if you see it visibly, there might be an orange line. You might see it around the neck. That orange line will dictate that because of the setup error or the patient's motion, that will account for the planning tumor volume. So we will add some kind of margins for the radiation to be given for the patient, at least 5 millimeter to 10 millimeter. It's very, very small margin, but we usually account it for the setup error. So there have been technological advances in radiation delivery techniques. When we started radiotherapy, it was very amazing, especially in black line. It was a 2D. We usually, like back when I was a resident in black line, what we did was we literally draw a line through the disease with a marker. So after drawing that tumor with a marker, we give it a field still with a marker, and we say that you have to give radiation treatment for these patients using the 2D technique. So you wouldn't see the tumor with a CT scan or other imaging. So it has been a very, very difficult way of giving radiation for these patients. So after that, there has come a new trend of radiotherapy, which we call it the 3D. So the 3D conformal radiotherapy is now being given across Ethiopia. It's being given in Blackline Hospital, Jimma, and Haramaya University hospitals. Now, Hawassa and Gondar has started the 3D conformal radiotherapy. It's very sophisticated radiation treatment using the CT simulation. So in the Western world, it's now even advanced more than the 3D conformal radiotherapy, and they call it the intensity modulated radiotherapy or IMRT. We are using also IMRT, but IMRT, it has been very difficult. It takes time, so we are not using IMRT that much. And in the very, very best setups, even in the world, there are only 100 centers which have proton beam radiation therapy. I have seen one in India, but even as a country, big countries only have one or two proton beam radiation treatment. So this has been really a great movement to see from 2D radiation techniques to 3D, then intensity modulated radiotherapy or IMRT, and nowadays the proton beam radiation therapy has been the one preferred. So these advanced techniques like IMRT or the proton beam radiotherapy enable improved tumor dose conformality and the tissue and organ sparing capabilities. So when you give radiation for cases like oral cavity cancers or we see a lot of patients with lip cancers, we see a lot of patients with tongue cancer, we see a lot of patients with buccal cancer and also tonsillar cancers and so on. So when you see these patients, usually they will have normal structures, or we call them organ at risk surrounding them. So when you want to give the radiotherapy using the external beam radiotherapy, which is photon, they usually will affect the normal structures surrounding it. So it's very difficult, to give a specific dose of radiation to the tumor and spare the normal structure. So in the Western world, in the best setups, what they recommend is to use this intensity modulated radiotherapy and also proton beam radiotherapy to spare the normal structures, which unfortunately we don't have proton beam radiotherapy, but we are trying to use intensity modulated radiotherapy techniques or the IMRT. Although IMRT and proton beam radiotherapy can reduce the risk of radiotherapy related toxicities such as mucositis, trismus, xerostomia, and osteoradionecrosis and abnormal development of orofacial structures, patients can still suffer from these complications, unfortunately, so resulting in a decreased quality of life. So let's see the complications, the main complications of radiotherapy. As dental surgeons or as dental physicians, when we send patients for you after radiation or be it chemotherapy, you might be wondering about the radiation type and so on. That's why I included the type of radiotherapy and so on. So the first complication usually seen after radiotherapy is oral mucositis. Mucositis is the inflammation of the mucosa, and it's associated with thinning and apoptosis or necrosis of the mucosa. It's the most common acute complication of head and neck radiotherapy, unfortunately. And the etiology of mucositis is the effect of radiation on mucosal cells. So radiation, it works in a different ways. There is a direct and indirect effects of radiation on mucosal cells. So the direct effects usually will obliterate the cells, and the indirect effects usually will be using the oxygen-free radicals, and this also will disintegrate the normal cell cycles of the cells, and also eventually will have toxicity. The radiation breaks the double-stranded DNA of the cells, and it's resulting in lethal damage. And oral mucositis is characterized by usually by pain, erosions, ulcerations, odynophagia, secondary infections. It might also have reduced oral intake, and in severe cases, the necessity for a feeding tube or total parenteral nutrition might be very necessary. In Ethiopia, we don't have TPN, which is total parenteral nutrition, unfortunately. But what we do is we usually will have a feeding gastrostomy tube, which will be inserted through the skin in the stomach. So the oral mucositis usually develops 2 weeks after the initiation of head and neck radiotherapy, and it may persist for 6 months after completion of radiotherapy. So imagine we will start radiation after 2 weeks, you will develop oral mucositis. So this has been very difficult for a lot of radiation oncologists, because the complications for the normal structures will overwhelm the patient's treatment. And this also might persist up to 6 months after completion of radiotherapy. Almost all patients receiving head and neck radiation plus or minus chemotherapy develop oral mucositis. Imagine almost everybody, every patient of yours will develop this oral mucositis. So how do we grade oral mucositis based on the WHO toxicity scale? When we say grade 1, it's usually is soreness or it's erythema. So when you open the mouth and see and examine the patient, you will usually see the soreness erythema. On the grade 2, usually you will see erythema and there will be an added ulcer. So you have to watch for whether there is an ulcer or not, because you don't have to downgrade the grade of this oral mucositis. And usually the grade 2 patients can swallow food well, so you won't have that much of a problem for these patients. For grade 3, you will usually see extensive erythema, ulceration, and patient cannot swallow food. So that has been the main problem for oncologists. Once they develop such kind of complications, it will be very difficult for you to keep the patient on radiotherapy, because these patients will not have the daily routine of eating food and so on. In Ethiopia, we usually eat high fiber diet like injera, which will require for the person to eat well and so on. So this is a major problem for us. For grade 4, it's extensive erythema and ulceration. So oral nourishment is impossible, which is very life-threatening. So such kind of patients, you have to refer for emergency, and they can be given at least a feeding gastrostomy tube, which will be inserted through the skin to the stomach. Otherwise, total parenteral nutrition in the developed world can be given easily. When you see grade 3 and grade 4, they are considered severe mucositis. And of the patients with severe oral mucositis, 70% require feeding tubes, and 62% of these patients require hospitalization for total parenteral nutrition, intravenous analgesia, and intravenous antibiotics. Unfortunately for us in Ethiopia, we don't have that much of luxury, so we usually give them a break from radiotherapy. Then after the break of the radiation, they will return to radiotherapy, and they might restart the treatment again. Otherwise, the complications you see in the whites and in the books, we don't usually will see them in an Ethiopian patient, fortunately, but most of our patients will have such kind of grade 1, grade 2 mucositis for the remainder of their treatment. So cessation of radiotherapy or a reduction in radiation dose is required by at least 35% of patients due to severe oral mucositis, so which then increases the risk of tumor recurrence or treatment failure. So in cancer, you always have to outweigh, because when you stop the treatment, there is a chance of reproducibility of the cancer cells, and they will replicate themselves and they will come back again. So when you attack the cancer cells, you have to make sure that there is no interruption or cessation of treatment. So you always have to comply with the laws of multidisciplinary team discussion and so on. We have to, as oncologists, we have to involve the dental side, so that there should be a clear follow-up of the patients from the outset. So how do we prevent and manage the oral mucositis? So amifostine is a very chemoradioprotective drug approved by the FDA. It will help reduce the severity of mucositis in patients undergoing adjuvant chemoradiotherapy for head and neck cancer. However, the problem with amifostine is it's limited in its use due to its associated severe side effects, such as rapid hypotension, nausea, vomiting, and it has also a narrow therapeutic window related to its rapid systemic clearance. So the use of proton beam radiotherapy for head and neck cancer has been shown to reduce the rates of acute complications such as mucositis, nausea, and also fatigue compared with IMRT. So, we can use amifostine. We don't have it in Ethiopia, unfortunately, but there are patients who buy such kind of drugs from India, Turkey, and also in US, and they will bring it to you, and they will ask you on how to use the treatment and so on. So you always need to look for that, and you have to read about it, because you can't say never in medicine, because in the OPDs, there are very rich individuals who can buy such kind of fancy or ancillary drugs in contrast to our daily type of patients. So the other option, which we don't have, is proton beam radiotherapy. Even in my practice over the past almost 8 or 7 years, I haven't seen any proton beam radiotherapy in Africa. I only saw one proton beam radiotherapy machine in India. Otherwise, it's very rare to see proton beam treatment in most of the African countries. So it has been shown to be very effective to protect patients from mucositis and other complications when compared to IMRT or 3D conformal radiotherapy or the 2D conformal radiotherapy, which we use in our setups. So systemic reviews and meta-analysis on photobiomodulation, which is low-level laser therapy in preventing and treating severe oral mucositis, concludes that it significantly reduces the rate of these acute complications in chemotherapy and radiotherapy patients. So, you can use photobiomodulation. This is a low-level laser therapy. I don't know if you have it in Ethiopia. We might discuss later on. Otherwise, it's one option of treating oral mucositis. The other one is cryotherapy. It has been shown to be effective in preventing several oral mucositis, and it has been suggested that the combination of photobiomodulation or laser therapy and cryotherapy will be more beneficial for patients. I know we use cryotherapy for cervical CA patients and also for wart and so on, but this is also another option for oral mucositis. And topical analgesic rinses and anti-inflammatory drugs and coating agents for pain control enable patients to eat, and antimicrobials aid patients at risk for infection. So, when you have especially an ulcer, you have to be very vigilant to see whether there is a risk of infection, and you can start those patients on antimicrobials or anti-inflammatory drugs. And also there are analgesic rinses that you can use easily. So you have to look out for those drugs. So this is a beautiful picture from the International Society of Oncologic Surgeons and also the multinational Society of Supportive Care Cancer. So you can see from the picture, these are some of the guidelines for oral mucositis. So the first one is a basic oral care. So you need to advise your patients on a good oral hygiene. So you have to tell them the time, the frequency, and on how to use the products and so on. The other one is anti-inflammatory agents. So you have to really tell your patients to use anti-inflammatory drugs. And this panel from the guideline suggests that the use of benzidamine mouthwash for the prevention of oral mucositis in patients with head and neck cancer who receive chemoradiotherapy. So you can use benzidamine mouthwash. And the photobiomodulation therapy and the cryotherapy, as I told you earlier, these are very effective treatments for oral mucositis. And the other ones are antimicrobials, especially coating agents and analgesics and so on. So topical morphine, at least 0.2% mouthwash is suggested for treatment of oral mucositis. So usually for these patients with head and neck cancer who are receiving chemoradiotherapy, you can give such kind of treatments. Others are very ancillary and very fancy drugs like growth factors can be given for these patients, and also from natural. Nowadays, even when you go to US or any European countries, they have this path called alternative medicine. So for anything that is beyond medicine, you can use natural treatments like honey. Honey is suggested for the prevention of oral mucositis in patients with head and neck cancer. In our setup, even in Blackline, when we were in Blackline, we used to use sodium bicarbonate with salt, which is called ersho. I know you know it from when you bake bread or something, we'll use sodium bicarbonate, so it's called ersho. So we usually use 2 teaspoons of sodium bicarbonate and with 1 teaspoon of salt, and we will mix it, and we will tell the patients to hold it in their mouth, and that has been effective for some of the patients. So you can use such kind of alternative medicine or natural treatments for patients, and this guideline clearly suggests that honey is another option for patients developing mucositis. So the second complication is trismus or trismus. So for trismus, it's a well-known complication of radiation therapy. It is defined as an inability to open the mouth or difficulty with mouth opening secondary to spasm of the muscles of mastication. So during radiation, usually when we contour the cases, we call it contouring. I know some of you, like if you are into aesthetics, there is now a line called contouring. So when you Google or something, they usually bring out the eyeliners and so on. But in radiation oncology, we call it contouring for drawing the tumor or the cancer on the CT scan imaging or and on the treatment planning software. That's why we call it contouring. So normal mouth opening or maximal interincisal opening in the healthy population, it ranges from 36 millimeter to 55 millimeter, which means that from 3.6 centimeter to 5.5 millimeters. There is really a beautiful picture I will show you. And the measurements below 3.5 millimeter are considered to be trismus. So you have to measure the interincisal opening, and trismus is associated with difficulty in many aspects of daily living, such as eating, maintaining oral hygiene, even to brush your teeth. That opening should be more than that, and receiving dental treatment as well as impaired speech. So this is really a beautiful picture. You can see from the picture that there is a maximal interincisal opening of only 6 millimeters. So this patient has developed radiation-induced trismus after radiation treatment. So it's very small opening, which is very difficult to eat or even do the daily routine things like brushing his teeth also. So it's very difficult, and it's one of the complications of radiation. So you always have to measure the interincisal diameter or opening for patients after radiation. So if it is less than 3.5 millimeter, it will be trismus. So the prevalence of trismus among head and neck cancer patients managed with IMRT, it ranges from 4% to 77.3%. Imagine. So it's a very wide margin, and these risk factors for the development of trismus includes a smaller pre-radiation maximal interincisal opening and increased radiation dose to the muscles of mastication. So unfortunately for us, we haven't yet started such kind of multidisciplinary team discussion with dental side, which we have to, because radiation treatment now is opening everywhere, especially in Ethiopia. Even in private centers, they are now trying to invest on radiation because it has been shown also effective in benign disease and so on. So we really need to have some kind of a team report discussion with the dental side, so that before the radiation, we need to know the patient's status. Like this, for example, from the normal physical examination of the patient, we need to have at least the pre-radiotherapy maximal interincisal opening diameter for each and every patient. Then after that, you can see the complications, and so it can be a baseline for later on. A study showed that the patient with pre-RT interincisal opening measurements of less than 4 centimeters were at risk of developing trismus. And the study by Tap et al. Reported that for every additional 10 gray of radiation to the medial pterygoid muscle, there was a 24% of probability of developing trismus. So it is important to note that most patients typically present with limited mouth opening secondary to mucositis and not due to radiation-related soft tissue fibrosis and trismus. So this is the one thing that I wanted to tell you, because we usually suspect that the patient has developed trismus because of the radiation and so on, but usually these patients have developed mucositis or some sort of infection even before the start of the radiation. So we need to be very vigilant to notice such kind of complications even before the start of radiation. So therefore, trismus can be either an acute or chronic problem depending on the etiology. So how do we prevent and manage trismus? So management of trismus is challenging, so practitioners should focus on prevention. So we usually say that we have to work on prevention, because once the patient developed the complication, it will be very difficult to manage the patient. So the patient should be always informed about these possible complications during a pre-radiotherapy dental appointment, as well as the need to perform regular mouth opening jaw exercise throughout the course of their radiotherapy. Conservative management of trismus includes the use of jaw opening devices such as terabyte, dynasplint, corkscrews, or stacked tongue depressors. These can be used to actively manage such kind of problems before the start of radiation. Nowadays, people are very focusing on the different types of exercise and the different types of this alternative medicine type treatments. So we really need to integrate exercises and also other normal diets into our daily practice. So the third one is xerostomia or hyposalivation. You know, xerostomia is the most common long-term complication seen in head and neck cancer patients following radiotherapy. So the term xerostomia and hyposalivation are frequently used interchangeably. But however, xerostomia is a subjective assessment reported by patients. They usually will tell you as dry mouth or unaltered taste. This we call xerostomia. However, hyposalivation is an objective assessment by the dentist or the dental surgeon or the oncologist of a reduction in salivary flow. This condition often limits the quality of life of patients regarding difficulty with mastication, speech, swallowing, halitosis, and also oral hygiene and dental caries. So the etiology of radiotherapy-induced xerostomia has been attributed to apoptosis or membrane damage induced dysfunction of the salivary gland. These are the acinar cells and the inability of the damaged stem cells to replace the apoptotic acinar cells. So the main risk factor for the development of radiotherapy-induced xerostomia is the dose of radiation to the salivary glands. As I told you earlier, we use a very, very high dose, especially for head and neck cancer patients, because most of the pathology or the biopsy is squamous cell carcinoma. So because of that, you have to give a higher dose, which is around at least 70 gray. This will be divided into 35 days, and it will usually affect the acinar cells in the saliva, in the salivary gland cells. So they will usually will develop xerostomia. Higher radiotherapy doses to the parotid glands predispose patients to xerostomia, although some patients may gradually recover within 24 months. So we always say to them that we have to wait at least 2 years before defining this xerostomia is irreversible or not. So a study by Osho demonstrated that the rate of radiotherapy-induced xerostomia was highest within the first 6 months after treatment and is reduced at longer follow-up times. And this, we call it Quantic guideline, were developed to minimize the risk of salivary gland dysfunction. The first rule is during our radiotherapy treatment, I always say to the medical physicist, to at least one of our parotid glands should receive a mean dose of less than 20 gray. Otherwise, if the dose is higher, both of the parotid glands should receive a mean dose of less than 25 gray. If we give more than such kind of doses, they will usually develop xerostomia, which will be very difficult for the patients. They will usually have a dry mouth. They can't eat well. Even the speech will be slurred and so on. So it has been a very major problem for us in the long run. So we usually will have a one-to-one discussion with the patients. And after that, it needs a clear discussion amongst the health professional providing radiotherapy. So how do we prevent and manage radiation-induced xerostomia? As noted earlier, amifostine is a chemoradioprotective drug approved by the FDA to help prevent moderate to severe xerostomia in patients undergoing adjuvant chemo radiotherapy for head and neck cancers. However, still amifostine is limited in its use because of the complications I told you earlier. They usually will have this hypotension, nausea, vomiting, and so on. So because of that, we don't usually order amifostine for our patients. Xerostomia can be managed with parasympathomimetics such as pilocarpine and also cevimeline. These are some of the drugs that will usually be prescribed for patients. Then systemic review and meta-analysis on the efficacy and safety of pilocarpine determined that pilocarpine was better than a placebo for symptomatic treatment of radiation-induced xerostomia in patients with head and neck cancers. So I know it's a bit fancy and these drugs are very expensive, but you can order pilocarpine for a limited number of patients which can afford to have the treatment abroad or which they can buy the drugs abroad and they can bring it to Ethiopia. So the salivary flow stimulants and also other saliva substitutes or oral lubricants such as sugarless chewing gum, biotin mouth oral rinse, or moisturizing spray and ACT total care dry mouthwash, and like that can be also used. But in our setup, what we usually will tell them is to have a chewing gum for at least it will help them to address such kind of problems. And we always tell them to have a bottle of water by their side. This can be also used at least to increase the salivary flow stimulation. And patients with xerostomia should be prescribed an aggressive fluoride regimen, and they should always be followed closely to help prevent or identify incipient dental caries. That's why usually after giving radiation, I usually will send our patients to the dental side. So the guideline still for xerostomia, it asks what is the efficacy of available pharmacologic or non-pharmacologic interventions for prevention of xerostomia induced by non-surgical cancer therapies? So it recommends that IMRT should be used to spare major and minor salivary glands. So IMRT, as I told you earlier, this is one of the radiotherapy modalities. It is called intensity modulated radiotherapy, and it has a good chance of sparing the organ at risks or the organs surrounding the cancer cells. When we give radiotherapy directly to the cancer cells or to the tumor, there will be normal tissues surrounding that tumor. So IMRT has been very effective to spare such kind of normal organs. Otherwise, in Ethiopia, we used to use the 2D radiotherapy, which was not very effective. It had a lot of toxicities. Then nowadays we are using the 3D conformal radiotherapy, which will be aided by a CT scan of its own. We call it CT simulator. And nowadays, in the best setups in different Western countries, they use the proton beam radiotherapy. The second recommendation is other radiation modalities that limit cumulative dose can be also used. This is also the proton beam radiotherapy and so on. And the third recommendation is acupuncture may be offered during radiation therapy for head and neck cancer cases. You will be very surprised in the developed world nowadays, you can see there is a place for alternative medicine, for Eastern medicine, and so on. Even when you go to China or Thailand or something, once the patients have a modern medicine treatment, if it is beyond the care of modern medicine, they will be given the chance to be treated in the alternative medicine pathway. So acupuncture is another possibility for at least treating xerostomia. The fourth recommendation from the Multinational Association of Supportive Care for Cancer Patients is systemic administration of betanicol. It may be offered during radiation therapy for head and neck cancer patients. So the second question is, what is the efficacy of available pharmacologic and non-pharmacologic interventions for the management of xerostomia induced by non-surgical cancer therapies? So usually topical mucosal lubricants or saliva substitutes. I don't know if you have it in Ethiopia. We can discuss it later on. I know there is a tear substitute, but I don't know if there is a saliva substitute. But in our setup, we usually will tell the patient to have at least water by their side, and they can drink water easily, and that can be a good source of lubrication to their mouth. The second recommendation is gustatory or masticatory salivary reflex stimulation by sugar-free lozenges. This can be gums. Usually, we will tell our patients to have a chewing gum, sugar-free chewing gum after radiation. And the third one is oral pilocarpine and cevimeline. These are some available drugs. And the fourth recommendation is the same as earlier, and we can still give those patients acupuncture. And also the fifth one is transcutaneous electrostimulation or acupuncture like transcutaneous electrostimulation of the salivary glands. So these are some of the ways of addressing the issues of xerostomia for patients who develop xerostomia after radiotherapy. So the fourth complication is the one which is very, very critical. And I know most probably in your OPDs or during your outpatients attachment, you might see patients after radiation with osteoradionecrosis. We call it osteoradionecrosis. This is the most severe complication encountered by head and neck cancer patients following radiation, unfortunately, and it is defined as an area of exposed necrotic bone in a previously irradiated area that fails to heal over a period of 3 to 6 months. So once you give radiotherapy, there are a lot of complications, especially in Ethiopia. We see a lot of patients in late stages like stage 3 and stage 4, which are very, very huge and very scary, and they will usually have an ulcer, or they will have wounds and also infections. And once you start them on radiotherapy, you will see a lot of worse type of complications like osteoradionecrosis. And this has been a major setback for our practice in radiation. But cases of radiographic or osteoradionecrosis with intact mucosa also have been described. So you have to watch out for that too, because the etiology of osteoradionecrosis has been attributed to the avascular effect of radiation to the bone, resulting in hypoxia, hypovascularity, and also hypocellularity. So when you see the risk for development of radionecrosis, it can be broadly divided into local factors such as radiation dose, because we give a high radiation dose. The radiation field, since when the patient comes to you with stage 3, stage 4 disease, you will usually cover a large area, so the radiation field will be very large, which will unfortunately will affect the organ at risks or the normal structures, and the proximity of the tumor to the bone. So imagine it's in the head and the neck. There are very critical structures. Once the tumor develops there will be proximity to the bone, unfortunately. Poor oral hygiene, like for example, if the patient has periodontitis before the start of the radiation, it will be very difficult, and they will have a risk of developing radionecrosis. And also traumas like dental extractions or dental alveolar surgeries, these are also other risk factors. From systemic risk factors, you have to see for whether these patients have immunodeficient status, whether these patients have comorbidities like diabetes, hypertension, and so on, whether these patients smoke or they use alcohol, and so on. And the third one is radiation to the head and the neck has been shown to increase periodontal attachment loss, resulting in mobile teeth, spontaneous exfoliation of teeth, and non-exposed breakdown of the alveolar bone. So we have to be very careful. And from this picture, you can see this is osteoradionecrosis in an oncology patient who received adjuvant radiation therapy for left tonsil squamous cell carcinoma. And the clinical image shows an exposed necrotic bone in the region of missing tooth, which is number 19. And this patient reported that number 19 tooth, unfortunately, spontaneously exfoliated. Then you can clearly see underneath it, there is an exposed bone, which developed radionecrosis. So this is the image of the same patient. This is osteoradionecrosis in an oncology patient who received adjuvant radiation therapy for left tonsil squamous cell carcinoma. This is a panoramic radiography, reveals pathologic fracture of the mandible. Unfortunately, you can see the left mandible is fractured, and this is a radiograph of the same patient in figure 7. So that's why when you see a patient, especially after radiotherapy, the patient might present to you with just a pain or an ulcer and so on. So you need to be very vigilant and alert to send such kind of x-rays or panoramic images to see whether there is an underlying damage or osteoradionecrosis. So how do we grade osteoradionecrosis of the jaw? So it's graded from grade 0 to up to grade 4. Grade 0 is only radiographic image with intact mucosa. Grade 1 is exposed necrotic bone without signs of infection for at least 3 months. Grade 2 is exposed necrotic bone with signs of infections or sequestrium, but not grade 3 or grade 4. When you see grade 3, it's resulting in pathologic fracture, and also this treated with successful surgical resection. So they will develop pathologic fracture, but it has a propensity to be treated with a successful surgical resection. For grade 4, these are refractory and they are very difficult to surgically manage. So you have to know the grade of osteoradionecrosis from grade 0 to grade 4. So the prevalence of osteoradionecrosis in the era of IMRT, it ranged from 4.3 to 6.8. Fortunately for us, I haven't seen such kind of advanced osteoradionecrosis for our patients, but you will find them now and then, and they usually will be in pain, and it will be very difficult for them to take anything, even liquid diet and so on. So you will be obliged to start them on feeding gastrostomy tube and so on. Fortunately, the prevalence of osteoradionecrosis has decreased over recent decades. This reduction in prevalence is attributed to advances in radiation delivery techniques. So these are the intensity modulated radiotherapy, the proton beam radiotherapy, which are very advanced ways of treating patients with radiotherapy. So when comparing 3D conformal radiotherapy, which we use in Ethiopia in major centers, to IMRT, the research shows that a reduction in radionecrosis from 13 to 6%. So as a country, even we need to implement this intensity modulated radiotherapy because it has a lower chance of damaging the bones and also causing osteoradionecrosis. However, it is important to note that a recent first study to evaluate the prevalence of radionecrosis in head and neck cancer patients treated with proton beam radiotherapy reported a prevalence of 10.6%. We don't have proton beam radiotherapy, but they are saying because of the higher dose of protons, proton are particles, but when you say 3D, 2D, or IMRT, we are using photon energy. Even in Ethiopia, most of the radiation treatment centers use photon energy. We don't use particles like electron, proton, neutron, and so on. These are very expensive, and they need a very expensive machine called cyclotron, which we don't have at our site. So this can have really a higher damage in their setup. Otherwise, in Ethiopia, we use usually a photon energy, which is an X-ray photon for treating patients. So the primary tumor site for the 13 patients that developed osteoradionecrosis ranged from base of tongue, tonsil, different types of oral cavity CAs. All 13 patients reported no precipitating trauma. So this is of interest because proton beam radiotherapy is reported to demonstrate a greater tissue sparing capability than IMRT, which is attributed to the inert property of proton particles, which is called Bragg peak. So usually when you treat patients with particles, they won't have this exit dose because when you use X-ray or photon, for example, if you want to treat the patient's breast, that photon energy will pass through the breast and goes out on the back of the patients. But for proton therapy, it's a particle, it will directly will treat the breast and it won't have an exit dose and so on because those particles won't be surpassing the body. But in our case, we use photon energy and they usually will have exit dose because of surpassing of that photon energy through the body of the patients. An earlier study on proton beam radiotherapy for the management of head and neck cancer patients reported lower rates of acute complications, which unfortunately we don't have at our setup. So in the best treatment centers, they use proton beam radiotherapy. Higher radiation dose remains a major risk factor for radionecrosis. Studies have shown that radiation dose of more than 60 gray to the bone are closely related to the risk of developing osteoradionecrosis. And a study evaluating the prevalence of this osteoradionecrosis, usually with cancer patients treated with IMRT, reported that 96% of the ORN affected sites received over 60 gray. So we have to be very careful when we give radiation more than 60 gray, which unfortunately in Ethiopia and multiple centers, because of the late presentation of the patient, we give a higher dose up to 70 gray. So how do we prevent and manage osteoradionecrosis? We see that both xerostomia and osteoradionecrosis are a very severe form of complications for these patients. So managing osteoradionecrosis can be very challenging, thus focusing on prevention is paramount. So all patients who are scheduled to undergo radiotherapy for head and neck cancer should have a comprehensive dental evaluation. That's why we need such kind of multidisciplinary team discussion with the dental side, and we need to have such kind of preparation before giving radiotherapy. During this pre-radiotherapy dental evaluation, patients should be counseled on the possible oral complications of radiotherapy as well as preventive techniques. A comprehensive oral examination should be performed, including panoramic and bite-wing radiographs, and if possible, a periapical radiograph when indicated. Prophylaxis or dental cleaning like topical fluoride application and detailed oral hygiene instructions should be also given. And dental caries and periodontal disease should be treated before starting or commencing radiotherapy. And indicated dental extractions. We have to be very vigilant on this because we usually will send patients with very locally advanced disease for dental extraction. So for non-restorable and unsalvageable periodontal involvities, it should be completed at least 2 weeks. When you plan to do dental extractions for these patients, you have to be very, very vigilant and you have to complete the extractions at least 2 weeks prior to the commencement of radiotherapy. In addition, a prescription for high potency fluoridated toothpaste should be issued, and these patients should be reevaluated at mid-radiotherapy, at the completion of radiotherapy, periodically every 3 months, at least for the first year, and every 6 months thereafter. I don't know if we have such kind of systems in Black Line, Jimma University Hospital, or Haramaya University Hospital, Hawassa University Hospitals, and Gondar University Hospitals, but we need to integrate such kind of tumor board discussions and also multidisciplinary team discussion for patients being treated on radiation. Invasive dental procedures such as extractions, deep root planning, and implant placement should be avoided as much as possible after head and neck radiotherapy. And if invasive dental procedures are necessary, the amount of radiation to the region of the jaw involved should be dosimetrically calculated. From our treatment planning software, which we use the 3D conformal radiotherapy, we can easily calculate the radiation dose. As dental surgeons or as dentists, when you come to our site, we can easily tell you the type of radiation and also the dose of radiation given to that specific patients. Extraction in an area of the jaw with a maximum dose point of 50 gray is discouraged. So this is one of the ways of protecting the bones, and the physician, the oncologist with the medical physicist, which calculates the dose, should be very assertive in addressing such kind of issues. In the developed world, in US, in Netherlands, in different parts of the European countries, they do have dosimetrists, which unfortunately we don't have in Ethiopia. But in Ethiopia, what we have is medical oncologists, radiotherapists, and also medical physicists. These are the people which will work together to treat the patient. So usually the medical physicist will be the one responsible to know about the dose of the radiotherapy, and he will address such kind of issues. So endodontic treatments are recommended, and decoronation of the tooth and root canal treatment of the retained root is also encouraged. And for doses more than 50 gray, you have to be very careful before doing such type of procedures. So there is no standard protocol in the management of osteoradionecrosis. Many different therapeutic approaches have been utilized based on the grade. So these are chlorhexidine or wound care can be given for local debridement, antibiotic and pain medication when indicated, at least until the exposed necrotic bone is loose and can be passively removed. Hyperbaric oxygen, I don't know if we have it in Ethiopia, but in the base centers, they might use hyperbaric oxygen. Pentoxifylline, tocopherol can be used, photobiomodulation or low-level laser therapy, and teriparatide, and surgical options like alveolectomy, maxillectomy, or resections can be done for such kind of disease. So head and neck surgical oncologists now consider the use of pentoxifylline and tocopherol protocol as the typical first-line management of osteoradionecrosis, and it has decreased the rate of major surgical resection and reconstruction. So in your setups, especially at the OPDs, if you find such kind of cases, especially with osteoradionecrosis, you can use the pentoxifylline and tocopherol protocol for treating such kind of patients. The final one, the final complications of the radiotherapy patients is abnormal development of orofacial structures. So radiotherapy to the head and neck of children can potentially lead to abnormal development of orofacial structures, especially in children. Rhabdomyosarcoma is the most common pediatric soft tissue sarcoma, accounting around 5 to 8% of all childhood malignancies. So this rhabdomyosarcoma is really an actively dividing, very difficult type of tumor. And the head and neck is the most common location of rhabdomyosarcoma. So management, it includes surgery, chemotherapy, and radiotherapy. So the following late sequelae of radiotherapy-related toxicities to the orofacial structures in children have been reported. The first one is facial asymmetry secondary to jaw hypoplasia, tooth agenesis, hypodontia or oligodontia, and also root agenesis or shortening or malformation can be there after treating these children with radiation. So reports of these complications have persisted even in the era of IMRT. But unfortunately, the severity of the orofacial developmental abnormalities is related to the age of the child at treatment. So when the children are very young, especially I don't know if you see the pediatric oncology side in Black Lion Hospital, you see that there are children below the age of 2, like even in menses, there are infants with different types of cancer. So when these patients are treated with radiotherapy, such kind of abnormalities might result, and we have to be very, very careful when we are raising the treatment. So younger children face greater risk and severity of orofacial development abnormalities, and the research shows that a radiation dose of more than 20 gray to the orofacial region of children places them at least 4 to 10-fold higher risk of developing dental abnormalities. So it's very, very difficult, and we have to address such kind of treatments with care, and we have to be very careful when we order or prescribe a higher dose of radiotherapy. Ameloblasts, tooth-forming progenitor cells, are damaged at a radiation dose of 10 gray. Imagine, they are very sensitive. And at 30 gray, tooth development is completely halted. So I don't know, it's very, very difficult to address the tumor, such kind of rhabdomyosarcoma, which are very resistant and which are very difficult tumors to treat with chemotherapy and other treatment. But when you give radiation, imagine just 10 gray can cause damage to the ameloblast, and 30 gray can literally halt the tooth development. So how do we prevent and manage this abnormal development of orofacial structures? Prevention of this late sequelae of RT for pediatric head and neck cancer may not be possible, as sparing these structures from the risk of radiation without compromising loco-regional cancer control is very challenging. And however, a pediatric dentist should be integrated in the care of children with head and neck cancers for close surveillance and management of these complications. So we need to have at least a guideline to develop when we address such kind of treatments for kids, especially below under 5. So the second one is the medical oncology patients. So when we see the medical oncology patients, this second part will address the role of dentists in the management of medical oncology patients. So oncologic patients on anti-resorptive or anti-angiogenic medications. The most common cancers in males and females in the United States are prostate and breast cancers, respectively. In Ethiopia, the most common cancer in females are breast cancer, cervical cancer, and colorectal cancer. In males, the commonest is colorectal cancer, and followed by lymphoma, and the third one is, I think, colorectal cancer, lymphoma, and then prostate. Advanced stages of many malignancies are associated with metastasis to bone. So once the patient comes to you with an advanced disease, with stage 3, they will usually have a metastasis to the bone. Hence, such kind of systemic treatment for these patients. Multiple myeloma and metastatic bone disease may necessitate the use of bone-modifying agents, we call them BMA, such as anti-resorptive medications, including intravenous bisphosphonates like pamidronate and zoledronate. In Ethiopia, we use zoledronate, left and right, and humanized monoclonal anti-rank ligand, which is denosumab. Some of the patients, especially those who goes to abroad, especially in Turkey and India, they usually bring denosumab. So these bone modifying agents help in the prevention of skeletal related events such as spinal bone compression, bone fracture, and surgery, as well as radiotherapy to the bone. So these anti-resorptive medications alongside other oncologic medications, imagine tyrosine kinase inhibitors, these are sunitinib and imatinib. So for example, sunitinib, we give it for kidney cancer, imatinib, we give it for GIST and other treatments, monoclonal antibodies like bevacizumab, mTOR inhibitors. There are different types of chemotherapy drugs or systemic drugs which are reported to be associated with medication-related osteonecrosis of the jaw. The previous one was osteoradionecrosis, but this one is medication-related osteonecrosis of the jaw. So medication-related osteonecrosis of the jaw is defined as an area of exposed bone or bone that can be probed through an intraoral or extraoral fistulae in the maxillofacial region that has persisted for more than 8 weeks in an area not previously irradiated or metastasis to the bone. So in a patient with a history of treatment with anti-resorptive therapy alone or in combination with immune modulators or anti-angiogenic medication. So you have to be very careful when you see a patient with osteonecrosis of the jaw. You have to ask whether the patient took radiation or not. If they take radiation, it might be osteoradionecrosis. But if not, you have to ask for such kind of systemic drugs like anti-resorptive treatments or immune modulators, we call them immunotherapy, and also antiogenic medications like bevacizumab, which we give it for colorectal cancer and other type of cancers like cervical cancer and so on. So the etiology is multifactorial. It includes bone remodeling inhibition, inflammation, infection. It also causes angiogenesis inhibition. It can be innate or acquired dysfunction, even it can be a genetic predisposition. So the risk factor for development of medically related osteonecrosis of the jaw can be broadly divided into three, as earlier. So the first one is local factor. For example, if you see a patient with dentoalveolar trauma, such as extraction or dentoalveolar surgery, poor oral hygiene, and also the anatomic location, usually mandible will be very affected than the maxilla. So these are some of the local factors. From the systemic factors, older patients especially, and female, those with comorbidities like diabetes or hypertension and so on, and smoking and corticosteroids, or for example, corticosteroids have a bone thinning effect. So the risk of developing this osteonecrosis of the jaw after tooth extraction among cancer patients taking anti-resorptive medication range from 1.6 to 14.8. So we have to be very careful once we start them on anti-cancer treatments or such kind of chemotherapy or immunotherapy, and also anti-resorptive treatments like bone modifying agents. They might have such kind of complications. So it is important to note that the cases of medically related osteonecrosis of the jaw without a precipitating dental trauma can also be present. So sometimes the cause might be cryptogenic, which you don't know. So you have to follow the patients well. So the stages are from stage 0 to stage 3. When you say stage 0, they usually have clinical or radiographic osteonecrosis with intact mucosa and no exposed bone. Stage 1, it has exposed necrotic bone with fistula that probes to bone without signs of infection. If they developed signs of infection or sequestrum, it will be stage 2. When you see stage 3, it's exposed necrotic bone or fistula that probes to bone with signs of infection and sequestrum. And also it will add at least exposed necrotic bone extending beyond the region of alveolar bone. It might have pathological fracture, extra oral fistula, and also it might have a communication with the oral structures, and also osteolysis extending to the inferior border of the mandible or the sinus floor. So once you see the stage, the risk is significantly greater, especially in cancer patients receiving these bone modifying agents, and more than those patients who takes anti-resorptive therapy for osteoporosis. Even cancer by itself has a damage to the cell-mediated immunity, and because of such kind of effects, it will have a larger effects for those patients taking the bone modifying agent. So you have to be very careful when we give such kind of drugs for our patients. This disparity is due to difference in the dose, frequency of use, and mode of administration of these drugs. And the risk amongst oncology patients taking zoledronate range from 0 to 18, which most studies say that less than 5%. And for oncologic patients taking denosumab, it's very small, and people prefer denosumab over zoledronate. Oncology patients on denosumab are at least at risk of developing this osteonecrosis of the jaw earlier. So when you compare the two drugs, denosumab versus zoledronate, denosumab, those taking denosumab will develop the osteonecrosis earlier than the zoledronic acid. And a study reported that cancer patients using denosumab developed osteonecrosis earlier or at a few doses compared with cancer patients using intravenous pamidronate or zoledronate. So you have to be very careful when patients bring you such kind of drugs with denosumab. It might be an earlier cause of osteonecrosis of the jaw. So how do we prevent or manage such kind of patients? The role of pre-medication dental evaluation. So this is a perfect way of addressing such kind of problems, because as oncologists, we need to have an integrated system to integrate the dental side and also have at least a clear plan before starting treatment of these patients. So the role of pre-medication dental evaluation in prevention of osteonecrosis of the jaw has been shown to be very effective in reducing the incidence of osteonecrosis of the jaw among oncology patients using anti-resorptive or anti-angiogenic medications. The study showed that a 12-fold decrease in the incidence of osteonecrosis of the jaw among oncology patients who received these drugs compared with patients who did not receive the pre-medication dental evaluation. So we usually need to have at least pre-medication dental evaluation. So it has shown at least 12-fold decrease. Imagine. So if the dental side evaluate the patient well and say that this patient clearly will be benefit from this drug without complication, it will decrease the complication by 12-fold. So studies from different research showed that they demonstrated a reduction in the incidence of this osteonecrosis of the jaw from 8.6 to 0 and 10.8% to 0%, but just by implementing this dental evaluation. So similar studies from other research also shown that the benefit of the pre-medication dental evaluation. So what does it entail? What does it mean, the dental evaluation? So it entails patient education, comprehensive dental evaluation, and completion of recommended dental treatment. So during this visit, oncology patients should be informed about the potential oral complications of this osteonecrosis of the jaw and the need to avoid any form of invasive dental procedures after commencing the anti-resorptive or anti-angiogenic medications. In addition, the patients are provided oral hygiene instructions, nutrition counseling, and a comprehensive dental examination should be performed, including panoramic or bite-wing radiographs, so and periapical radiographs when indicated. So prophylaxis, dental cleaning, and topical fluoride applications are indicated as well. So before starting the patients with such kind of treatments, we need to have at least a good way of dental evaluation. Dental caries and periodontal disease should be treated as soon as possible, and indicated dental extractions should be done at least 2 to 3 weeks prior to the anti-resorptive medications. In addition, a prescription for high-potency fluoridated toothpaste should be provided, and these patients should be periodically evaluated. So in oncology, we always follow patient every 3 months. So the dental cleaning follow-up and the oncologic follow-up should match. So we have to follow these patients every 3 months for the first year and every 6 months thereafter. So there are different management approach based on the stage. Also, we can use chlorhexidine, rinse for local debridement, and antibiotic and pain medications also are other options of treating these patients. And the use of other non-surgical options are like tocopherol or pentoxifilin or photobiomodulation as for the osteoradionecrosis. This can be used successfully. And due to the unpredictable and protracted course and varying success rate of non-surgical approach, surgical options like maxillectomy or resection, segmental resection should be considered in the management of medical related osteonecrosis of the jaw. and they say that surgical options have reported to be with high success rate. So from the guidelines, the recommendations are, they will ask what steps should be taken to reduce at least the risk of medically related osteonecrosis of the jaw. So you always, when you give this bone modifying agent, BMA means bone modifying agents, you need to have a comprehensive dental, periodontal, oral radiographic exam whenever possible. And based on the assessment, a dental care plan should be developed and implemented. The care plan should be coordinated between the dentist and the oncologist to ensure that medically necessary dental procedures are undertaken. And the second recommendation say that modifiable risk factors like members of the multidisciplinary team should address modifiable risk factors for patients with medically related osteonecrosis of the jaw with the patient as early as possible. These risk factors include poor oral hygiene, invasive dental procedures, ill-fitting dentures. This has to be managed. And recommendation 2.3 says that elective dentoalveolar surgery can also be very, very beneficial for these patients. So whenever there is a possibility, it's better to do it elective. And recommendation 2.4, it says dentoalveolar surgery follow-up. After doing such kind of surgery, the patient should be followed systematically and also frequently, at least every 6 to 8 weeks, they should be followed. And recommendation 2.5 says that temporary discontinuation of bone modifying agents should be also considered, especially for patients with cancer who are receiving bone modifying agents at an oncologic dose. There is insufficient evidence to support such kind of claims, but if it is severe, you might need to stop the treatment and commence later on. So how should we manage the medically related osteonecrosis of the jaw? The initial treatment is usually conservative measures should be comprised, like it might include antimicrobial mouth rinses, antibiotics if clinically indicated, effective oral hygiene, and conservative surgical interventions such as removal of superficial bone spicules might be done. And the second recommendation says that if it is refractory, aggressive surgical interventions like mucosal flap evaluation, block resection of necrotic bone, or soft tissue closure may be used. And if these persistent symptoms or affects function despite initial conservative treatment. So such kind of aggressive surgical treatment can be recommended, but this intervention is not recommended for asymptomatic bone exposure. So we have to be very careful when we do such kind of treatments. And the final question says that should bone modifying agents be temporarily discontinued after a diagnosis of medically related osteonecrosis of the jaw? So for patients who are diagnosed with this while being treated with bone modifying agents, there is sufficient evidence to refute such kind of claims, but you have to personalize or individualize your treatment plan based on your patient type. In Ethiopia, we usually will stop the treatment because it's very painful and we don't have any potent drugs. Even for morphine, we only have an IV morphine. We don't have oral morphine. We don't have PO like oral solutions of morphine. So it's very difficult, and these patients will be in severe pain, and it's very difficult to treat them and control their pain. So for me, I always go for stopping the drug and maybe see the disease cascade. After that, we can manage accordingly. Then the final topic is hematopoietic stem cell transplant. This is widely used in the management of malignant and non-malignant hematologic diseases such as leukemia, lymphoma, multiple myeloma, plastic anemia, and immune deficiency disorders for the purpose of immune system reconstitution following conditioning. So this form of oncologic therapy renders patients severely immunocompromised and at risk of bleeding prior to, during, and long after the therapy. It can be secondary to cytopenia or thrombocytopenia. So during this period of immunosuppression, patients are at an increased risk of infection with potential for systemic spread. So with leukemic patients or with those patients with lymphoma, it's very difficult to treat them. So you as dental surgeons or as dentists, these patients will usually have poor oral health and they will be predisposed to different types of bacteremia, odontogenic infections, and so on. And their morbidity and mortality is very higher. So this stem cell transplant or also causes mucositis and salivary gland dysfunction. So oral mucositis usually begins a week after initiation of conditioning and continues for 2 weeks after the end of conditioning. So another complication that arises after allogenic stem cell transplant is a chronic graft versus host disease, which occurs within several months after the transplant in a high percentage of patients. Chronic graft versus host disease affects multiple organs. It affects skin, eyes, gastrointestinal tract, oral cavity, lungs, and liver. So as dentists, you have to be very careful to address such kind of issues because these patients are very fragile patients and they are very difficult to treat because they do have different complications. Their cell lines, almost all of their cell lines will be affected and the different organs will be they will be very affected. So oral chronic graft versus host disease is characterized by ulcers, erythematous, or lichenoid lesions. So before the stem cell transplant, it should include a comprehensive oral evaluation and completion of recommended dental treatment. So a comprehensive oral examination should be performed, including panoramic and bite-wing radiographs. And for evaluation of dental caries, periapical, periodontal bone pathology should be assessed, and the status of third molars also should be there. And following the oral evaluation, the recommended dental therapy such as caries control, endodontic therapy, periodontal therapy, which can be like prophylaxis, scaling, and also root planning, and also topical fluoride applications are to be completed as soon as possible. Indicated dental extractions for non-restorable and unsalvageable periodontal involved teeth should be completed at least 2 weeks prior to the commencement of the transplant or high-dose chemotherapy. So in addition, a prescription for high-potency fluoridated toothpaste should be provided. The timing of dental procedures during the transplant dental clearance in these patients should be coordinated with the medical team. The patient's hematologic laboratory results should be reviewed for complete blood count. So you have to order complete blood count like white blood cell count, absolute neutrophil count, and platelet count before performing any dental procedures to avoid the risk of infection. As I told you earlier, all of their cell lines might be affected, especially those leukemia patients. You have to be very careful before doing any kind of procedures, and you have to order a complete blood count panel. So a patient with severe neutropenia, which is defined as an absolute neutrophil count of 0 to 499, is at risk of life-threatening infection and should be isolated and hospitalized. The only treatment that should be performed is palliative care under antibiotic prophylaxis, oral antimicrobial rinse, and post-procedural antibiotic regimen for a week. So no routine care should be completed on this patient. So as dentists and dental surgeons, you have to be very careful when addressing and evaluating such kind of patients with severe neutropenia. Patients with moderate neutropenia, which is defined as an absolute neutrophil count of 500 to 999, they are at moderate risk for infection. They should be given antibiotic prophylaxis, oral antimicrobial rinse before any dental procedure, and post-procedural antibiotic regimen should be given for 5 days. While patients with mild neutropenia, an absolute neutrophil count of 1000 to 1500 are at a mild risk for infection, they can receive routine dental care without antibiotic prophylaxis, except for some instances for major surgery, such as multiple dental extractions and post-procedural antibiotic regimen for 5 days. So these patients are literally almost the same with normal patients. They are not that much difficult, but for those with severe neutropenia and moderate neutropenia, you have to be very careful. And patients with platelet count of less than 20,000, these patients might bleed spontaneously. So whenever you face with a cancer patient, an oncologic patient, you have to be very careful about the diagnosis, and you have to see that whether their CBC panel is normal or not. Then the immune checkpoint inhibitors or immunotherapy, these are not that much common because they are very, very expensive. Even some of the drugs are very, very expensive and not available in Ethiopia. There are biosimilars like pembrolizumab or nivolumab. We have their biosimilars from India, which are the drugs that mimic the normal structure of the drugs, the immunotherapies, but you can buy them at a lower cost, and they come from India. We use them for some of our patients, but these drugs are also another set of drugs that you have to be very careful. So these immunotherapies have been approved by the FDA for a subset of patients for head and neck cancer. So they can have risk factors like xerostomia, mucositis, and lichenoid reaction, and also osteonecrosis of the jaw. So you have to be very careful also when dealing with ipilimumab, pembrolizumab, or nivolumab. We are treating some of our patients like esophageal cancer, gastric cancer patients with these drugs. And whenever patients develop mucositis, xerostomia, and if they are an oncologic patients, you have to ask about their treatment and whether these patients are taking such kind of immunotherapies, chemotherapies, and so on before giving them any kind of treatment. So conclusion, as dental practitioners, you all play a crucial role in the management of the head and neck radiation oncology or medical oncology patients, from making the initial diagnosis of the oral or pharyngeal cancer to the identification and management of the associated oncologic therapy complications. So pre-radiation therapy, anti-resorbative, anti-angiogenic medications, and the pre-transplant dental evaluation is an essential management in the prevention and management of these complications. So each comprehensive head and neck medical oncology team should have a dentist integrated in the care of these oncologic patients. Finally, these are my references. I used different types of references and one good research paper. So you are welcome to see the paper. Finally, thank you. And I really love the song from The Weekend. It might make our mood a bit casual. So with a good pain control and with a good opioids, I think any surgeon can control the patient disease well. So thank you so much.
Thank you very much, Dr. Mikhail. So any questions from the participants, please write it down on the chat box so that we can have a discussion on the subject. So since we get other questions, let me ask you something, Dr. Mikhail. So from your practice, what's the most common complications you see with radiotherapy in your context?
Yeah, the most common is oral mucositis. We do see a lot of oral mucositis cases. Unfortunately, these patients, will come for you with a pain and ulcer, and it's been very difficult to address such kind of issues. Otherwise, xerostomia is also another complication, but in Ethiopia, we started radiotherapy almost a year or 2 years back. So we don't see that much of patients with xerostomia because these patients won't come to the OPDs and clinics. And you won't find them in the OPD at least. So for me, at least, I see a lot of mucositis cases. Otherwise, the other like osteoradionecrosis of the jaw or like that, we don't see them that much. I can't say that.
Okay, so from your experience from the abroad also, can you please suggest us a way to collaborate with dental professionals and health professionals associated with oncology care?
Yeah, fortunately for me, I really learned even for myself, teaching, they say teaching is twice learning. So even when Dr. Vasika approached me and like wanted to read about the different types of multidisciplinary team discussions and the tumor boards in the well-developed countries like US and so on, there is the role of dental surgeons and dentists is huge. But in Ethiopia, we are not yet well organized or made our tumor boards or multidisciplinary team discussions with the dental side. But I feel like there is a need, a huge need to fill the gap between oncologists and dentists and so on. Even I learned in Netherlands, Rotterdam University, and I attached there for a week. And I have been also in Ghana for 2 months, especially training on IMRT and VMAT. And I recently also went to the US and saw the City of Hope hospitals. So abroad, they do have really a good setup of multidisciplinary team discussions, a tumor board involving every health professionals and practitioners, which can address the issue of their patients well. For us, at least, there is oncology is a very advanced profession, but in Ethiopia, it's still in its infancy. I can say that it's very young, and we only have few oncologists, less than almost 50 oncologists all over Ethiopia. And the tumor board discussions or the multidisciplinary team discussions hasn't been well developed in different setups. Even during my practice or residency in Black Lion Hospital, we didn't have that much of a setup for such kind of discussion. So for me, at least, it's good to have this discussion, and hopefully we have a society, Ethiopian Society of Hematology Oncology. I see a need for integration. I see a need for cooperation, and we all are here for our patients, and cancer patients deserve the best treatment. And we do have a lot of good professionals like you all. So I think if we integrate and cooperate together, we can have our own research. Now in Ethiopia, we have more than 5 functional radiotherapy centers in Black Lion Hospital, Jimma University Hospital, Harame University Hospital, recently Awasa University Hospital and Gondar University Hospital have started radiation treatment. So if we integrate this systematically, we can address a lot of problems which are being faced by each and every one of us at the outpatient department. So I feel like we need to have such kind of cooperation amongst ourselves.
Thank you very much. That was a really great response. So we have few questions. Let me go through them one by one. So when treating post-radiotherapy patients, how do you balance the need for extractions or restorations with the risk of complications like osteoradionecrosis? Are there any clinical decision frameworks that we can rely on?
So for extraction, usually that's why the need for the tumor boards or the multidisciplinary team discussions, because we need an earlier, as discussed earlier, they all say that the prevention is better than the management. Especially in Ethiopia, for us, we usually will give a higher dose because our patients we usually will present after stage 3 and so on. So these patients will be in stage 3 and stage 4, and we give a higher dose of radiotherapy, which is around 70 gray. So this will be very difficult, especially if you see patients after radiotherapy, and if they come to you to the dental clinics. I think you will be very fascinated with the effects of radiation to the bone or to the oral cavity and so on, because it's very difficult. So for me, at least, there should always be, we should always focus on the prevention, and there should be a clear communication between the oncologist and the dental side before doing the extractions. And they recommend, based on the guidelines, the international guidelines, they recommend that we need to do the extraction at least 2 weeks earlier before commencing radiotherapy. After radiotherapy, I don't think it will be very possible, and the complications will be very dramatic. And these patients, once being given radiation, it will be very difficult to have a proper treatment of the oral cavity. So I urge everyone to have a clear plan before the radiotherapy rather than after radiotherapy. So I will maybe share the PowerPoints and also the guidelines from the multinational society of supportive cancer care. So they can see such kind of guidelines. There are also guidelines from the International Society of head and neck surgeons or oncosurgeons. So that is also another good guideline to see and review for every one of us.
Oh, wonderful. So, for those with experience of managing trismus or xerostomia, what conservative interventions have you found effective in improving patients' quality of life?
It's a good question. Like practically, you know, from science perspective, we can say a lot of things for trismus and also for xerostomia and so on. But clearly, in Ethiopia, we are not using such kind of treatments because they are very expensive. For example, if you take amifostine, we don't have amifostine in Ethiopia. Even pilocarpine, you wouldn't find it that easily. But for me, the prevention is a good one. But for example, during oral mucositis, especially starting from black line, we usually use alternative medicine pathways. Like, for example, we will tell them to use sodium bicarbonate or ersho, 2 teaspoons of sodium bicarbonate mixed with 1 teaspoon of salt and mix it and maybe hold it in their mouth. And for xerostomia, we usually urge them to chew a gum and especially sugarless gum, and also to have a water. For everyone, we usually urge them to bring 1 liter of water by their side. And for Christmas, it's been very difficult for us to tell you the truth because it has a very gruesome effect for the patient because these patients won't be feeding or won't they can't talk to you in a way that you want and so on. So and it's their first time to have such kind of complications. So usually what we do in our radiation setup is we will stop the treatment for a while for 2 to 3 weeks, and they will usually have a good response for that. We can give them anti-pain and also mouthwash for those patients. And also in some cases we can give antihistamine treatment. Some of our guidelines also urge us to give antihistamines because they will decrease the inflammation at that site. Then after a while, if you evaluate those patients, they will have a response and we can restart the treatment. Meanwhile, you have to know these patients might have a worse outcome because the tumor might regrow and also might come again because you can't stop the radiation and restart again. So it needs individualization, and you have to. Every patient is different. One patient will be different from the other. Some of them they might be very sensitive for the radiation toxicity. The others might not. So I always say that you have to give a proper anti-pain. You have to have a good evaluation of the oral cavity. When we usually face such kind of problems, we usually will have a chance of communicating the dental side. And once we do have that kind of communication, if there are ulcers or inflammation, antibiotics, antihistamines, or non-steroidal anti-inflammatory drugs will be given for those patients, and they will usually have a response. Our patients are way different than the whites. So our experiences during our radiation treatments are way different than the white ones. So it should always be individualized and based on your patients. So you have to personalize your treatment based on the effect of radiation.
Okay, so as a practicing oncologist, have you come across any oral cancers? And if you so, what are some of the common ones that you have faced? And what can you say about their prognosis?
Yeah, well, in Ethiopia, it's very common, by the way. Like the commonest we face from the oral cavity CAs are tongue CA, especially when you go to the eastern part of Ethiopia, which I work. I work in Jijiga and also I work in Haramaya University. I also work in Black Line or in Addis Ababa for our private center. So you see a lot of tongue CA patients, lip CA patients. We see oropharyngeal cases and also tonsillar CA. You will see different types of cases even. So it's not like they are very rare, because in Ethiopia, what we lack is we don't have a proper cancer registry. So everything will be extrapolated from the Addis Ababa Cancer Registry. We only have one adult cancer registry, which is Addis Ababa Cancer Registry. So the numbers I show you earlier on from the early slides are those which were extrapolated from the Addis Ababa Cancer Registry. When you come to Jijiga, for example, you see a lot of esophageal carcinoma cases, because in cultural practice, they usually have these hot beverages, and also the way of living in their diet is way different than the one living in the capital city or from the northern city. And if you see, there are different types of risk factors. For example, in Addis, for example, some of the patients might be alcoholic, some of the patients might be smokers. So you'll see different types of cancer cases, but I haven't seen that much of different type of cancers like the whites, because our way of living is way different than the Western world. But otherwise, we do see different types of oral cavity cells like lip cancer, tongue CA, buccal mucosa CA, and so on. These are the commonest, and from oropharyngeal, we see a lot of tonsillar CAs and so on.
Okay, so as dentists, we normally use intraoral periapical X-ray. So when we are treating patients with liver cancer who are receiving chemotherapy, so what is the recommended number of intraoral periapical X-ray that we can give them? Because we mostly use it during root canal treatment. So do you have anything to say about this one?
Come again, I didn't get the question. For liver cancer patients.
Yes, liver cancer
Uh,
patients who are undergoing chemotherapy. So
okay.
what kind of intraoral periapical X-ray should they receive, or is there any recommended usage or any kind of dosage that is
Okay.
underway?
So for liver cancer, hepatocellular carcinoma, especially in Ethiopia, it has a poor prognosis. Even when you see books, especially, it can be divided for those patients who can be treated surgically or early liver cancers. These are patients undergoing treatment surgically. This will be good for the patients and the prognosis will be good. But in Ethiopia, we usually face patients with locally advanced disease. So these patients will have a poor prognosis. And from our book, it says the prognostic index is mainly they might live up to 6 months or maybe to 1 year and so on. So if it is liver cancer, the prognosis is poor. So I urge you to see what kind of liver cancer it is. We have a score called child PUG score, and we usually do different types of tests. Once we do triphasic CT scan, which is a CT scan specifically done for liver cancer, we'll use child PUG score. This score will include the serum albumin, serum bilirubin, the coagulation profile like the PT-PTT, INR index, and they will usually also include the ascites and also encephalopathy score. Once you determine such kind of a score, whether the liver is compensated or decompensated, you have to underscore based on this grading. If the liver is compensated, no problem. We usually will start them different treatments like chemotherapy or targeted therapy like sorafenib and so on. But if it is decompensated, we usually will put them on palliative care or supportive care, because liver cancers are very difficult to treat. So for oral treatment, I urge you to be very careful with liver cancer cases, because the coagulation profile will be affected once the liver is affected, and there is a high chance of bleeding from this patient. So if it's possible, you have to order the complete blood count panel and the coagulation profile like the PTT, PT-INR score of these patients, and you have to communicate the oncology side whether this patient has a surgically resected liver cancer case or not. So based on that, at least you can have any kind of treatment. If it is surgically resected and if it is a compensated liver, you can treat him as any other patient. But if the patient is not surgically treated and if he's put on chemotherapy, which usually will be palliative, or targeted therapy, which will usually be palliative, so you have to be very careful, and very simple dental procedures should suffice. You don't have to do any other major dental procedures.
Okay, so are there any red flags that we need to watch out in order to diagnose intraoral cancers?
Oh, nice question. So for intraoral cancers, there might not be any red flags because it's easy. The oral cavity, you can easily see it with our naked eyes, or we can have a lamp or light and can see for ourselves. Some of the patient might present late and with a locally advanced disease and so on. But I always say that if you suspect a malignancy or a CA, at least you need to have a corroboration with imagings. You need to have at least an X-ray or a CT scan to know the extent of the disease before doing anything. Otherwise, as discussed earlier, this CBC panel is very, very important, and it should be integral part of your treatment. But for me, treating oral cavity cancers is very easy than the others. For example, if you take nasopharyngeal carcinoma, you can't see the tumor unless you do have an imaging like CT scan and so on. But fortunately for us, if a patient has oral cavity cancer, it is easily accessible, and you can see it with your naked eye. And imagings can also be very important. And usually these oral cavity cancers, they will usually have supply like with lymph node and so on. So you might find lymphadenopathies on ipsilaterally or contralaterally. So these cervical lymph nodes surrounding the internal jugular vein or jugular lymph node chain would be easily accessible even for biopsy or treatment. So for me, it's better to order imagings before approaching any disease because that will help you to stage the disease and individualize the treatment. So head and neck CT scan would be good to order, or if it is early, you can order an X-ray. And based on that, the systemic, before taking any kind of or doing any kind of procedure intraorally, you need to check for the systemic signs and symptoms of the disease with CBC, liver function test, renal function test, and also coagulation profile for the patients.
So you have mentioned that we should complete all necessary dental works before the cancer therapy begins. But as in reality, sometimes referrals come late. So
Yeah.
how can we manage this kind of situations in this tight timelines?
Candidly speaking, you are right. Like frankly speaking to you, like we don't usually refer patients unless they tell you there is signs or symptoms of intraorally, or they have such kind of mucositis or something. But in previous times, when I was a resident, especially in Blackline Hospital, what we used to do was every head and neck patients will be referred for at least a dental evaluation. And even before starting radiation, we will refer for the patients to the dental side for better evaluation. Once the dental side says that this is okay, we will start radiation. But nowadays, I think the number of patients are increasing a lot, and we see the investigations are getting sophisticated and so on. So people tend to use their own kind of diagnosis, doing CT scan and so on and so on, but they will neglect the very important things like the evaluation before treating these patients and so on. But patients and the disease won't lie. Once you start radiotherapy, these patients, if they have some kind of problems with their tooth or intraorally, they will usually will have the complaint of dental caries and so on and so on. So in that case, as dental surgeon, as dentist, you might not do anything, but for me at least, the most important thing would be it is to have some kind of communication or cooperation among the dental side and the oncology side, and to have a tumor board discussing such kind of cases, because we do see a lot of head and neck cases, especially oral cavity cancers, and such during such kind of interaction between the dental side and the oncology side, there should be a clear communication. And if this happens, you have to consult us for better treatment and for better evaluation. And you have to tell the oncology side frankly that after treating the radiation, there isn't that much that you can do personally or as a department and so on. So for me, at least, it's a big lesson to have a tumor board or multidisciplinary team discussion amongst ourselves. That way, we can protect such kind of late presentations or late call for the dental side.
Okay, so I think we're almost wrapping up. Just one question. So, as dentists, I think this is the main focus that we need to work on. So, can you say a few words on the impact of poor oral hygiene or the lack of dental follow-up in the impact of the prognosis in the treatment outcome of cancer patients, especially undergoing chemotherapy or radiotherapy?
Is a question for me?
Yes,
Oh, I thought it was from your side. Yeah.
I can repeat the question.
Okay.
So I think this is something that we need to focus on as dental professionals, but I just want to have your input on that. Maybe you can say a few words on the impact of oral health or the lack of dental follow-up on on the prognosis in the treatment outcome of cancer patients, especially the ones who are undergoing chemotherapy or radiotherapy.
So let me tell you our secrets then, because during radiation or radiotherapy, these patients will develop mucositis. Usually, if we didn't consult these patients or advise these patients about their oral hygiene and how to keep it, and also maybe use the proper way of pre-medication dental evaluation, it will be difficult it will be very difficult for them to complete the treatment. Usually, once the patient is started on radiotherapy, after a week or two, they almost all of them will develop mucositis. So because of this, the oncologist or the radiation oncology nurse will be evaluating the patient for the oral cavity, picking for mucositis or other complications like that. So for me, at least, it's very important to have at least the dental evaluation for head and neck cancer cases, especially in Ethiopia. They usually will present late. They are usually in older patients, which previously used which were smokers, or they were drinking alcohol and so on. We used to have this laugh about the head and neck cancer cases, by the way. ምን እንል ነበረ? We say that head and neck cancer cases lived life to the fullest because they used to drink, they used to smoke, and they are promiscuous on their sexual pattern and so on, because of like that. Because the risk factor, if you read about head and neck cancer cases, the most common risk factors are HPV, EBV, smoking, alcohol, drinking alcohol, and so on. So you have to be very careful in dealing with these patients. They might have comorbidities. They might be very old. They might used to have smoker. They might used to be smokers or alcohol drinkers and so on. So they always will have a need for pre-medication dental evaluation, and it's very, very vital, and it's very important. Like once you start radiation and giving a high dose of radiotherapy, which in our case, usually for head and neck cancer cases, we give up to 70 gray. And most of our patients are being treated with 3D conformal radiotherapy or VMAT, which is a volumetric arc therapy. So these patients will have a complication like mucositis, and in the long run, they will develop xerostomia and so on. So we have to be very careful, and if not, they usually this complication will double, and they will come to you with pain and with infection, with ulcers, and your OPD will be full of them. So I feel like the dental side has a big role to play for this oral cavity CA patients and also head and neck cancer patient in general. And coming to also the systemic disease, like those patients who are using bisphosphonates, or in our case, we use zoledronic acid for most of our patients because our patients develop stage 4 disease and they will come with metastatic disease. We usually order zoledronic or zoledronate for breast cancer cases, for prostate cancer cases, which has prognosis more than 3 months or 6 months. So we'll start them on that, and they might have a risk of osteonecrosis of the jaw. So these patients also are eligible to be evaluated by the dental side for this. So I always urge that we need to start them on proper dental hygiene, and also we usually will prescribe anti-pain, antibiotics, and also mouthwash, which are important for dental care in general. I don't know if it answered your question, but I feel like the dental side should have a better seat in treating these patients in the future too.
Oh, thank you very much, Dr. Mikhail. It's very critical that we also acknowledge ourselves as part of the comprehensive healthcare. So I want to thank you for taking your time from your very crowded and busy schedule. Then I want to let you know that our participants that the post test will be posted on our official Telegram page, and I recommend you to go and do it after the link ends. So we also have another promotion to go through, and it is on August 17th. It's our next Pan-African webinar with Dr. Abdullah from Somaliland on infant oral mutilation. So thank you very much, Dr. Mikhail. If you have any closing remarks.
Thank you so much for inviting me. It's been a pleasure. I really loved the discussion, and hopefully I will be part of your society too, and we can work together in the future on research and also guidelines and so on, because we need such kind of guidelines, nation-based, Ethiopian-based guidelines for our patients, because we are now giving radiotherapy in 5 major cities, and hopefully 2 others will join from St. Paul and Mekelle. So hopefully everyone should come together, and we are a scientific community, and we need such kind of comprehensive support from each other. So I really had a good time, and I enjoyed every second of it. And thank you to Dr. Fasika for inviting me for this awesome panel discussion. Thank you so much.
Thank you very much, Dr. Mikhail. And we will also hold you up to your work because we need to work on oral cancer and cancers of the oral cavity. So thank you very much for your time, and I will urge our participants to go to the post test. And thank you very much. The webinar has ended for today. Have a great night.